Hello, my name is Dr. Ominde. We're with the lecture series on retroperitoneum and retroperitoneal structures. So here we'll discuss retroperitoneal vessels, and the first one is the abdominal aorta. So the abdominal aorta is 13 centimeters in length. Where does it begin? At the aortic hiatus. Remember, this is located at the level of T12. Where does the abdominal aorta terminate? At the fourth lumbar vertebra, the abdominal aorta terminates by bifurcating into common iliac arteries on the right and the left side. This termination is 2 to 3 centimeters inferior and to the left of the umbilicus at the level of the iliac crest. So umbilicus is visible, iliac crest is palpable. So 2 centimeters inferior to the umbilicus and towards its left at the level of iliac crest. That's how you identify, that's the surface landmark of the abdominal aorta. The abdominal aorta divide or bifurcate into right and left common iliac, and this usually will diverge and move inferolaterally. Okay, they follow the medial border of the psoas muscle and then towards the pelvic brim. What happens to these common iliac arteries? They will now divide into an internal iliac and external iliac arteries. Internal iliac will now enter the pelvis to supply the pelvic viscera, while external iliac usually follows iliopsoas muscle. What happens to the external iliac? Just before leaving the abdomen, it usually gives inferior epigastric and deep circumflex iliac arteries. Inferior epigastric and deep circumflex iliac are branches of external iliac artery before it leaves the abdomen, and they go to supply the anterolateral abdominal wall. Then how does the external iliac leave the abdomen? It passes below the inguinal ligament, and at mid-inguinal point, it continues to the lower limb as femoral artery, so it enters the femoral triangle. What are the relations of the abdominal aorta? The abdominal aorta anteriorly, what structures are found from superior to inferior? The celiac plexus and ganglion, the body of pancreas and the splenic vein, before you get to the left renal vein, the horizontal part of the duodenum, and the coils of the small intestine. So this is the order from superior to inferior. So you have the celiac ganglion, the body of the pancreas and splenic vein, left renal vein, horizontal part of the duodenum, and the coils of the small intestine. So the aorta usually gives paired branches and unpaired branches. Paired means you're giving both to the right and the left side. So immediately after it enters the abdomen via the aortic hiatus at T12, it gives the first branch. And the first branch is inferior phrenic artery that will supply the diaphragm and also supply the suprarenal glands. So the unpaired, that's the first paired branch of the aorta. So it's the inferior phrenic. What are the unpaired branches of the aorta? You have the celiac trunk. Celiac trunk gives splenic artery to the spleen, left gastric to the esophagus and the stomach, and common hepatic artery. Then there is superior mesenteric to the mid-gut derivative, inferior mesenteric to the hind-gut derivative. Celiac trunk is what supplies the foregut derivatives. So foregut, celiac trunk, mid-gut, superior mesenteric, hind-gut, inferior mesenteric, then there is median sacral. So these are the unpaired. These are one single branches, yeah? Then the paired ones, you have inferior phrenic to the suprarenal glands and the diaphragm. The middle suprarenal, they come directly from the abdominal aorta. Then the renal arteries, then lumbar vessels, there are 4 of them, before the aorta terminates by dividing into right and left common iliac at L4 vertebra, and each common iliac divides into internal and external iliac arteries. Anterior branches are given off at T12 derivatives. Superior mesenteric leaves the abdominal aorta at L3, supplying hindgut derivative. So you need information because of your MCQs, unpaired branch, phrenic, diaphragm, and the terminal branch aorta at L4 divides into right and left common sacral artery that goes downwards. So again, this just explains what each artery, you need to know what each artery supplies, and I've already gone through that. So you can pause your video and go through the blood supply by these different vessels. This also explains the anterior unpaired branches, celiac, superior mesenteric there, and inferior mesenteric at L3. Okay, then the paired, you have renals, you have inferior phrenic, suprarenal, middle suprarenal, you have renal, you have your gonadal vessels there, 4 lumbar arteries. Then it terminates by dividing into right and left common iliac and median sacral. Common divides into internal iliac to the pelvic viscera and external iliac. At the mid-inguinal point, external iliac continues as femoral. Remember, external iliac gives deep circumflex iliac and inferior epigastric to the anterolateral abdominal wall. So bifurcation of the aorta occurs at L4. Celiac trunk is given at T12, superior mesenteric at L1, inferior mesenteric at L3. What are the relations of the aorta? On the left, there's sympathetic chain. On the right, there is inferior vena cava and cisterna chyli. Then on the sides, there's azygous veins, the para-aortic lymph nodes, and the celiac ganglion. Anterior to the aorta is a pancreas, splenic vein, left renal, third part of the duodenum, the mesentery, stomach, omentum. So you need to know all this for your sake of your MCQs. And when you're asked to write an essay on the aorta, and you need to state what structures are found anterior or posterior to the aorta. So this just shows you the branches, okay, the paired branches and the level at which they are given. Again, this shows you the branches of the aorta, so you can pause the video here and look at the branches. Look at celiac trunk, superior mesenteric, inferior mesenteric. Inferior mesenteric is here. This is gonadal. Then this is median sacral going downwards. These are the common iliac, internal iliac, external iliac, middle suprarenal, inferior phrenic, middle suprarenal, renal, gonadal, the lumbar vessels, which are 4. Okay. Again, you need to pause the video here and study this image very well. Look at the branches and where they are supplying. Look at how celiac trunk gives left gastric, splenic, and common hepatic. Common hepatic now gives then gastroduodenal, then continues as hepatic artery proper that gives right and hepatic artery branches. Then the gastroduodenal is what gives the right gastroepiploic. It gives the superior pancreatic, posterior gastric to the stomach, as well as left gastroepiploic. And the splenic artery also supplies parts of the spleen. Inferior vena cava. Okay, this usually begins anterior to the L5 vertebra. What forms inferior vena cava? The union of right and left common iliac veins anterior to the left, the L5 vertebra. This union occurs 2.5 centimeters to the right of the median plane. Okay, and it's usually inferior to the bifurcation of the aorta and posterior to the proximal part of the right common iliac artery. So you need to get the atlas and be able to check that this occurs inferior vena cava. The common iliac unite 2.5 centimeters to the right of the median plane, and this is inferior to the bifurcation of the aorta and posterior to the proximal part of the right common iliac artery. It usually ascends on the right side of L3 to L5 vertebra and on right psoas major. Inferior vena cava is to the right of the aorta, and it leaves the abdomen via the caval hiatus or opening of the diaphragm. The venacaval opening of the diaphragm is at T8 vertebral level. Esophageal is at T10, aortic hiatus is at T12. Inferior vena cava is formed 1 vertebral level inferior to the bifurcation of the aorta. So bifurcation of the aorta was L4, so this will be 1 vertebral level inferior. Then it passes the diaphragm, traverses the diaphragm 4 vertebral levels superior to the aortic hiatus. So inferior vena cava, we said, is at T8, while the aortic hiatus level superior to it. Inferior vena cava is 7 centimeters greater than the abdominal aorta. Okay, although the length, most of the additional length is intrahepatic. So most of the length of the IVC is intrahepatic. The IVC collects poorly oxygenated blood from the lower limbs and also collects non-portal blood from the abdomen and the pelvis. Remember, the GI contents with nutrients from the GI, they will be carried to the portal vein. They're carrying nutrients. But we also have the GI needs to carry deoxygenated, it also has deoxygenated blood. The deoxygenated blood now will follow the inferior vena cava, while the one with nutrients from the GI will follow the portal system, to the portal vein. Okay. What are the tributaries of the inferior vena cava? They correspond to the unpaired visceral branches of the aorta. Okay. They correspond to the unpaired visceral branches of the aorta. Okay. And these unpaired visceral branches are instead tributaries of the portal vein. So the blood that is carried by tributaries of the inferior vena cava, it will enter the inferior vena cava via the hepatic veins. Okay, so the unpaired visceral branches. The unpaired visceral branches are branches that are following inferior mesenteric, superior mesenteric, celiac trunk. Remember, those are from the GIT, so they're carrying nutrients. Okay, so they will enter the portal vein first, from superior mesenteric vein, inferior mesenteric vein. So inferior mesenteric vein will get to splenic vein. Then blood from splenic vein will join superior mesenteric vein to form portal vein. Portal vein will enter the liver through porta hepatis. So how does this blood eventually get to the inferior vena cava? From the liver now, portal vein to the liver. From the liver, that blood enters hepatic vein. Okay? Bifurcation veins now open into the inferior vena cava. So blood from the GIT, the unpaired visceral branches from the GIT, do not directly go to inferior vena cava. They first go to portal vein to the liver. They're carrying nutrients. Then from the liver, the nutrients will be taken up by the liver and stored. Then the blood will enter hepatic vein to return it to inferior vena cava. We continue with the tributaries of IVC. Now we are discussing the paired visceral branches. So like the suprarenal veins, the renal veins, gonadal veins. So what happens to them? So these paired visceral veins, okay, the right suprarenal vein, right and left renal vein, and right gonadal vein, they drain directly into the inferior vena cava. So what happens to the left suprarenal and left gonadal? Now, left suprarenal and left gonadal drain indirectly to IVC. What do I mean? They first go to left renal vein before they get to IVC. Remember, the inferior vena cava is on the right. So you can see the left suprarenal and the left gonadal. They first have to go to left renal before left renal takes it to IVC. But on the right renal is here, right suprarenal, right gonadal. So on the right side, they go directly to the IVC. While on the left side, the left suprarenal and left gonadal have to pass through left renal to get to the inferior vena cava. We continue with tributaries of the inferior vena cava. We have the paired parietal. These were paired visceral. They are going to viscera, suprarenal gland, the kidneys, the testes, and the ovary. So these are paired visceral branches. Then we have paired parietal branches. They are going to the body wall. So inferior phrenic to the diaphragm, the lumbar veins to the body wall, the lumbar region, and common iliac veins, which are formed as union of external iliac and internal iliac. So these will drain into the IVC. The ascending lumbar and azygous veins, they connect the inferior vena cava to the superior vena cava. So there's a communication between superior vena cava and inferior vena cava through ascending lumbar and the azygous vein. So go back to the lecture on posterior mediastinum and look for how the azygous vein forms. Is between the subcostal vein and ascending lumbar on right to form azygous, and subcostal and ascending lumbar on the left to form the inferior hemiazygous. So this gives a communication between superior and inferior vena cava. Remember, azygous vein, if hemiazygous vein is a tributary of azygous, then after that azygous goes to drain into the superior vena cava. So these provide communication between IVC and superior vena cava. So this we have already talked. Just pause your video here and look at the veins and the tributaries of the inferior vena cava. Again, this you just need to pause and look at the tributaries of the inferior vena cava. Notice the absence of veins draining the viscera, the stomach, spleen, pancreas, and intestines. Those ones will have to first go through portal vein to the liver, then from the liver through hepatic veins back to the inferior vena cava. Again, just pause and look at the relations of the inferior vena cava and look at the tributaries of the inferior vena cava and how the left suprarenal and left gonadal first have to pass through left renal to get to the inferior vena cava. So what are the relations of the inferior vena cava? Anteriorly, you have the liver, the epiploic foramen, which is the opening of the lesser sac, which is the omental basa, the first part of the duodenum, the head of the pancreas, third part of the duodenum, superior So to go through this, open your atlas and make sure you can locate all these structures and make sure you can confirm they are anterior to the inferior vena cava. So this is the inferior vena cava, and posteriorly you can appreciate the lumbar vertebra, the posterior crus, the right crus of the diaphragm. Then you'll have right renal artery. The sympathetic trunk will be paravertebral there. So those are posterior relations of the. Then this is what we said, that from the hindgut, venous drainage is to the inferior mesenteric. From the midgut, they'll follow superior mesenteric. Then foregut derivatives will be through celiac trunk. So this hindgut and midgut, the hindgut will join, inferior mesenteric vein joins splenic vein. Splenic vein and superior mesenteric form portal vein. These blood-carrying nutrients enter the liver. Deposit the nutrients in the liver, they will be stored. Thereafter, the blood through hepatic veins, right, left, and middle hepatic vein, will be later drained into the inferior vena cava. Then these are the other tributaries of the inferior vena cava. So from the GI, they indirectly go to inferior vena cava to the liver via the portal vein. But the rest drain directly, they are direct tributaries. Then you can see the right ascending lumbar will be used to form azygos on the right, and the left will be used to form inferior hemiazygos on the left. So pause and look at all the tributaries of the inferior vena cava and how right and left common iliac are actually the ones forming the inferior vena cava. So we are going to call collaterals of the abdominal pelvic venous blood. So these collaterals are valveless, so blood will flow either way. Remember, valves ensure unidirectional flow. But if these are valveless, it means flow is on either direction. So when you have these collaterals, you're able to allow blood to return to the heart when the inferior vena cava is obstructed. If somebody has a cancer in the abdomen that is blocking the inferior vena cava, how will blood from the lower limb get to the heart? It should be able to go back even if inferior vena cava is obstructed. So if you obstruct the inferior vena cava at this area, blood is coming this way from the lower limb. It needs to still get to the heart even if there is an obstruction around this region. How will it do that? Number one, using the superior and inferior epigastric veins. Okay, using the superior and inferior epigastric veins. Number two is through the thoracoepigastric vein. This is in the anterior abdominal wall, using the thoracoepigastric vein in the anterior abdominal wall. And then using epidural venous plexus. These are outside the vertebral column. So here, the lumbar veins communicate with the azygos system. So superior and inferior epigastric veins on the anterior abdominal wall, thoracoepigastric veins also help with that connection between inferior vena cava and superior vena cava tributaries. Remember, like the axillary and inferior epigastric. Inferior epigastric vein drains into IVC. Axillary drains through subclavian to superior vena cava. So there's communication there. Superior epigastric is from internal mammary, from subclavian to superior vena cava. Inferior epigastric through the iliacs, through inferior vena. So this is a point. These collaterals show you how inferior and superior vena cava communicate. So if there's an obstruction through inferior vena cava, these vessels can communicate and still drain the blood. So thoracoepigastric vein is a lateral superficial anastomotic channel. It's a superficial channel between superficial epigastric, okay, from femoral vein, which will end up to external iliac vein, common iliac vein to inferior vena cava. But there's also lateral thoracic from axillary vein. So thoracoepigastric, axillary vein, and the iliacs eventually will communicate. So if you have an obstruction of the inferior vena cava, blood will now have to use the superficial vessels on the anterior abdominal wall between superficial epigastric and lateral thoracic vein to go back to the heart through the superior vena cava. Then we have other anastomotic channels between superior and inferior epigastric veins, where inferior epigastric is from external iliac vein to IVC, while superior epigastric, internal thoracic subclavian to superior vena cava. So when there's compression of IVC, these anastomotic channels will dilate and give an alternative pathway. So that's what you call caval-caval shunt. You're shunting blood from the inferior vena cava system to the superior vena cava system. That's why it's called a caval-caval shunt. Okay. So like for example here, so if you have an obstruction here, blood will come from the lower limb, but instead of passing through the inferior vena cava to go to the heart, it will come to use these branches of the tributaries of the inferior vena cava that will go and communicate with the tributaries of superior vena cava that will carry the blood through superior vena cava into the heart. So you bypass the portion of the inferior vena cava that is obstructed. So from the lower limb, like that, then you go and use the tributaries of the inferior vena cava. They will eventually communicate with the tributaries of the superior vena cava on the anterior abdominal wall through the subclavian, axillary and subclavian vein, brachiocephalic vein back to the superior vena cava into the heart. So you bypass the obstructed portion of the inferior vena cava. So next lecture, we'll briefly discuss the nerves that are in the retroperitoneum. Thank you.